strain tells you about the left ventricular performance, and we have, as Dr. Legation showed about the biplane Simpson method of looking at the ejection fraction. So if you have this kind of image, there is something called frame rates. The frame rates are 43. So if you have frames of 43, it will be very difficult for us to get the strain values, because it should be 50 to, the recommendation says around 50 to 70. So every machine has something called frames per second. So I will not be able to do, I will not be able, I'm just explaining.
Lower images.
Yeah, I will do. I'm just explaining, sir. I'm just explaining. I will go for it. So, thing is, you cannot acquire on this frames. We need 50 to 70. That is one thing. Second thing is, we are going to do left ventricular global longitudinal strain. So, strains are of three types: longitudinal, circumferential, and radial strain. Please don't try to remember circumferential and radial strain in a day-to-day clinical practice, because it has not been validated. It is only for research purpose. So the only thing which is acceptable is global longitudinal strain. So for global longitudinal strain, we need three images. We need the apical 3-chamber view, apical 2-chamber view, and apical 4-chamber view. Do you have three? I can sit here. So we generally start with the apical 3-chamber view. See, the recent, all these machines are now very advanced machines, and they do all automated thing. But before knowing the automated thing, you should know how to do it on a day-to-day basis, because every person may not have an E95 or a Epic series of Philips. So even if you have an entry level, if you have a strain thing, you should be able to do it. So the first thing is the 3-chamber view. This is the 3-chamber view. The reason we do a 3-chamber view is that because we need to time the cardiac cycle, and the best way to timing the cardiac cycle is by looking at the aorta. So aortic valve closure is taken as one of the important way of identifying the contraction of the left ventricle. Okay, please stop me if you don't understand every step. So whatever I am trying to tell you is very important. The first view to acquire is apical 3-chamber view, because you are getting here the aortic valve. Aortic valve closure coincides with the cardiac cycle. Is it clear? Okay, and this next view is the 4-chamber view, and the third view is the 2-chamber view. These are the views you acquire. Is it clear? Right. Now, we will go to the 3-chamber view. You can identify the whole of endocardium very clearly. You know that the LV's performance is poor, the LV ejection fraction is poor. I think if it is the same patient, Dr. Allegation, it was EF was around 20%. So we'll see. So there is a software. We go to AFI, and I will go manually. Let's do it manually. So let's not have an automated thing. Otherwise, they will get confused. So there is something called three-click thing. So what does it do is, we have to identify the structure. So this is the posterior basal. So remember, global longitudinal strains give you subendocardial strain. It is the subendocardial contraction of the left ventricle which you are identifying. While circumferential strain gives you the epicardial, bahar wala, epicardial strain. So we are not interested in that. So this is the posterior basal, this is the anteroseptal, and I see the apex. And it will give me a tracking, which is in this call, it is yo-yo. So it is analyzing it with the aortic valve. Okay, it is analyzing by itself. So I will just click process, and it starts giving me various kind of beautiful waves. Okay, so the global longitudinal strain in apical 3-chamber view is minus 4.7, and these are the regional values. So this is, if you see this graph, this is the timing of aortic valve closure. Okay, ideally speaking, all the waves should go like this. It should be, there has to be a flow up to here, and it should go behind. But if you see the yellow part, which this is this part, the blue is here, they are just moving at random, and the peak is not at the aortic valve closure. The peak is just before it. Okay, am I clear till now? Okay, then we go to, so, and this can also be represented from this quad. This, see, if you can see, the Nyquist limit is -20 to +20. So, -20 -19 is generally considered to be normal. So, the peak is happening before the aortic valve closure here in this segments, but few of the segments are not contracting pretty well. I will do the same thing in apical 4 chamber view. I will approve this slide. So, it will again ask me the references. This is the septum, this is the lateral wall, base and the apex, and I have to adjust little bit. So, it is a poor LV, it is almost a globular LV, and I will process it, and it gives me more information, similar pattern. There is a lot of dyskinesia, and I will go to the 2 chamber view and do the same thing. The machine also does automatically, but just for the sake of thing, I will just process this fast. Okay, and we have good information. So now, so this is what is now a very important picture. It shows you a global pattern. It is called a global longitudinal strain. It is -5.6. Why is it minus? Normal is around -19, -20. Why is it minus? Because it is going away from the transducer. It is contracting. Okay, it is shortening. Normally is around -20. Now there are various values in the anterior septum, in the anterior, lateral, posterior, everything. This regional values should not be mentioned. Don't mention the regional values, only mention the global longitudinal strain. But you can always identify a pattern, how it is looking at. So, we can always see that the apical is contracting slightly better than the other sides. There is something called apical cherry on top appearances, which goes in favor of amyloidosis. Lot of patterns. Is it clear till now? Any questions?
Can you explain how to read these lines?
Right. So now, as I was coming to that. So now, as you can see, this is the global longitudinal strain is 5.6. Now, regarding the 4 chamber view, 2 chamber view, and 3 chamber view, as you can see, none of the segment of the myocardium are contracting at the timing of aortic valve closure. Do you have any normal patient in this? Because this is a patient of dilated cardiomyopathy, everything is haywire. Ideally, all the segments are going to contract like this. If you see my arrow, they are going to go like this, and they should go this. There is a lot of synchrony in all these views. So you can understand there is a lot of dyssynchrony happening between the various chambers. Does it answer your question? And segments.
Yeah, so like the yellow represents the base.
So, if you can see, if I can go to the single thing, let's go to quad. So, if I see, this is the red one, okay? So, this was the red segment, okay? This is the blue one, so this is the blue thing. But the problem is, regional segment value is not validated. It is only the global value of.
So, what is the clinical relevance of these line diagrams?
Clinical relevance of line is that there is a lot of dyssynchrony. It is a pattern which you have to identify. Does it translocate to any significance? The answer is no. It has not been identified to have any prognosticator. You should always say the
problem is
the LV ejection fraction is around 20%, while the global longitudinal strain is -5.6.
The problem is what he is trying to tell is as he said, all the segments should converge at the aortic valve position in the pyramid patient like this. In this wave, this green segment and rose segments, they are contracting, but their amplitude is less. Number one, you can deduce certain things. But while all the segments should contract, these segments are moving away. These are all shortening segments. These are all lengthening segments. That means he wants to insist that uniformity of synchronous contraction in this patient is not there. Dysynchronous contraction is there in this patient. what does it indirectly implies?
Lot of
This
dyssynchrony
dyssynchrony will lead to subsequently arrhythmia and sudden cardiac death. This dyssynchrony should not be there. Definitely,
So you can do that.
you select this. This
Yeah.
point.
So what
This 59 frame or 50 frame? 59th frame. 59th frame. Yellow marker. This green and yellow. This.
Yeah, I will do it. Okay,
This
I will.
one.
I will
This
do-
one.
Yeah.
This PSD is peak systolic dispersion. Normally, it should be less than 48.
48.
The cutoff mark, if it is more than 71, that means there is no synchronous contraction in this patient, and patient will suddenly go in for sudden cardiac death. And
Yeah.
That is the this is useful for CRT.
It is useful for CRT.
So
Yeah,
this
you have
is-
a question. Yeah, we can do the septolateral delay and everything. So there is something called myocardial work index, which we can surely talk about it, but that's slightly on the higher side. And there's a guy called Russell who had worked on this concept of the efficiency of the heart. Yeah. Uh-huh. Yellow line which was going above. Is it dyskinesia? Where is it? Let's see. Okay. Where is the yellow line? Yes, this is going away. Yes, you are correct. It is dyskinetic. Absolutely
When
correct.
we mention in our reports,
There's no point in
segment
say
disconnect.
it doesn't give you any significance. No. The point is segmental contraction, segmental values are not validated. So the answer is don't mention it. No. Ma'am.
Yeah, good afternoon, sir. I have a question to ask you. Do we have to select a selected number of loop beats while we are doing the strain, or just one beat does the?
I think I generally, I mean, they recommend this suggestion is to have the 3 beats acquisition and take the best beat wherever you can do. A single beat, we have seen that subsequently post processing, if the things are not taken very well, can have problems. What is your opinion? We can do in single beat also.
No, I usually record single beat, multiple.
Yeah, the same thing. Acquisition, the same thing.
4 acquisitions in 4 chamber, 3 or 4 acquisitions in 2 chamber, and 3 or 4 acquisitions.
Yeah,
You
so
can select the best
I
one.
take 3
Now,
beats,
because
multiple acquisitions. Take
If
the
you,
best.
if you select a 3 beat loop,
Any other
I
question
cannot
you
select the beat.
Right.
It's
Any
very
other
difficult to
question you have?
select the beat.
Any other
They
question you
ask
have?
the machine to do this beat only, that beat only.
Right.
Yeah.
Did you speak
Thank
about
you,
the
sir.
post-systolic contraction?
No, I was going to that. There are already questions in this. Okay, so there is some. Okay, you can just show that. Show that case. Yeah. So what Dr. Nanda wanted me to show. Where is it? So in this case, it is not there, sir. Okay, it is there. Yeah, it is here. How do you? It is a saved data. All right. So so as we all said that the whole contraction or all waves should be at the aortic valve closure, but sometimes few of the waves can go beyond the aortic valve closure, which is called post-systolic contraction. So this wave, can you see this? The green one is peaking after the aortic valve closure. Would like to say something on that? Yeah. Yeah. So
This post-systolic contraction denotes it is a sign of ischemia.
ischemia.
That is the number 1 point. Sometimes post-systolic contraction can occur in younger individuals also. That is a normal variant. If it is so, it should occur in the first 20% of that aortic valve closure. Then in the normal individuals, velocity will not be reduced. Whereas in the case of coronary artery disease, velocity will be delayed and reduced. Along with that, the post-systolic contraction duration will be more than 20%.
20% of the.
So that denotes that there is a coronary artery disease evidence. We cannot say this is an infarct or ischemia, but this is a sign of coronary artery disease, post-systolic contraction. Exactly.
Yeah, yeah.
Exactly.
Any questions?
But that post-systolic contraction is not there in 4 chamber and A-flat.
No. So in this
Segment is not
in
contracted.
this part, it is most likely fibrotic. There is a dyskinesia. So
So can we have localization also with this, that in the inferior wall?
it is a pattern you should be able to helpful. So let's say if the whole thing is red and this part is becoming yellow or its part is becoming blue, then you can tell that it is an LED territory which is getting problematic. And then you look at the aortic, at the apical fourth chamber view and look at the post-systolic contraction at that segment. So it is a pattern which is important to be identified. Right? Any questions?
Please don't try to see too much conclusion.
Yeah.
Don't draw too much conclusion.
Yeah.
Because this is a patient with dilated cardiomyopathy. If you ask me whether this patient is having an ischemic dilated cardiomyopathy, whether there is coronary artery disease,
Not possible.
nobody can tell from this. Even if you say the post-systolic contraction wave, the present ischemia and all that, it cannot say. So the main thing is minus 17, minus 18, minus 19 are normal. Minus 17 is up to minus 17 is normal. Minus 16 is suspicious. Minus 15 or below. The
Is
value
bad.
is below. Definitely it is reduced. The strain is reduced.
So it is global longitudinal strain, not a segmental strain.
Segmental strain. And minus 8 or below, the prognosis is very bad.
Poor. Yeah, you had a question.
Regarding the placement of the markers on the area of interest, both the septal and the prima, to avoid the possible errors, how do you suggest the
Yeah, so I will tell you. Can you
And
go back?
again, mask the thing.
Yeah.
Say you should not select the insertion point. You should go a few millimeter away from the insertion point into the annulus.
So this is the click. So what he's telling, we should not be here. Okay,
Little
you
inside.
should be just inside.
Outside.
Okay, so you have to be in the myocardium, not at the AV valves. Don't be here. At the base, you have to be here. Okay, don't go at the aortic valve. That's the point, right? And
The apex.
and the apex is the point where you have to identify your apex, not here. The apex is not here. The apex is somewhere here. And then once you get it, you can always adjust the thing.
And the other thing is the region of interest
Yeah.
should not include the pericardium. The parietal pericardium should not be included. The brightest line should not be included in the region of interest.
So here also it is giving us some idea. See on the right side. See, this is all AI driven thing, but you may not be having it in the lower end machines. But as I said, if you are in the pericardium, then your values will go down. Right? So do we have time for left atrium? I don't know what is next.
Yes. It is another 12 minutes. I think.
Oh, that's nice. So how many of you are doing LV strain?
I want to add one point.
He wants to add something. Please.
One more point regarding the number of beats that I do routinely record 2D from all the three views: apical 3-chamber, 2-chamber, and 4-chamber. And in addition, the triplane view from the 3D probe, so that in patients who have arrhythmias, atrial fibrillation, or frequent ventricular ectopics, the triplane view, single triplane view, you will have all the three views in the same beat. So that is the advantage of using the triplane view. Can you show the triplane view?
For the 3D triplane view. Where is it? Yeah.
This is the triplane view, which is easily obtainable with your 3D probe. And in a single beat, you have all the three views simultaneously. So that is the advantage in patients who have frequent arrhythmias, atrial fibrillation, multiple ectopics. Your separate acquisition of the 2D derived 3-chamber, 2-chamber, and 4-chamber may not match. It will say, the machine will say rates are different, and you will not be able to record the strain in those patients. So in those patients, please select the triplane view from your 3D, and then you can proceed with the strain analysis.
Yeah.
So one very common question and a practical question. Echocardiographically, left ventricle ejection fraction is 60, but when we compute the GLS, it's about 12 or 10. How should we report it? Because the person will become hypochondriac if we say that this is...
It is an important thing. So let's see. My report goes like, so let's say he's an hypertensive guy. So I will say hypertensive heart disease, concentric LVH, LV ejection fraction of 60%, type 2 diastolic dysfunction, E by E prime of 11, GLS of minus 12.1, no MR, whatever it is. So you are identifying subclinical LV dysfunction. It is a marker of early HFpEF. Please tell, you have to tell the patient that there is subtle LV dysfunction going on. He has to better control his blood pressure, whether check his BNP, So as a clinician, he is going into early HFpEF. And I will tell you, you make him exercise, just make him run or walk, his things may parameter may change.
He is in
Yeah.
stage B of heart failure.
He is in stage B of heart
He
failure.
is
Yeah.
in stage B of heart failure. That is
Preclinical.
Because see, the thing is, when you
No,
look
it's
at
not.
ejection
It's-
fraction, you can get a very good idea how the valves are moving. See, if the machine says 60%, I know it's probably normal. But when it comes to strain, there is no way to tell. So you really have to depend on the number. And do you depend on the number all the time? No. So you really have to make sure that we discussed this before. You have to make sure that the image quality is very good. You have to really traced it very well rather than coming and telling that you got dysfunction. What I tell the patient that we have got one value here which looks abnormal, but we are not sure that is correct or not correct. But for sure, I can tell you that your ventricle is contracting very well. That much I can tell you. So this one we'll have to check and see later on. So we don't want to create a disease in a patient when there is no disease. So we have to be very careful about
But
this.
I think, sir, I will beg to differ in this.
Exactly.
No, I will beg to differ in this because I will tell you. No. So I will beg. So what's happening is first, what he made a point is very important, that we should have a good image, because if you have a foreshortened LV, then your LV strains may change. But if you are getting, let's say, minus 12.1 in a hypertensive guy, so there's a lot of work. Please get an anti-pro-BNP. Kindly ask the patient to exercise, because if the E by E prime changes on exercise, that means you're doing a diastolic stress test. This minus 12.1 is a stage B phase. So this has to be a structural problem where it is in hypertensive LV dysfunction is occurring, and this, if you don't treat these patients well, then they can have a progression of the disease. So I think it's very important to be cautious, but try to run more tests. Try to have an anti-pro-BNP, try to have a stress test, and then give the patient that information.
Problem here is LV ejection fraction is an volumetric method.
And also the circumferential strains are compensating for the GLS.
Exactly.
Yeah.
That's what the ejection fraction is obtained.
Right.
In this case, in the hypertensive heart disease, because of the subendocardial fibers are first affected,
Correct.
that gives you a warning signal. The subendocardial function is affected. That is why your GLS is affected.
Correct.
Why your ejection fraction is normal? The circumferential fiber is contracting and makes the ejection fraction normal falsely.
Yeah.
That means this patient has got myocardial structural disease, but which is not reflected in the ejection fraction. But that means this patient has got subclinical LV dysfunction, that is preclinical. That is what Professor Alagasan said. Preclinical.
In the United States, we don't try to do many tests. What I would do with a patient like this is when he comes for a follow-up, again, I will check and see. And sometimes in the same patient, if I do the strain twice, he'll have a different number, quite different number. So you really have to be very careful with these new technologies. So don't label a patient, maybe we miss some, maybe Dr. Shantanu is right, that patient may have a problem, but on the other hand, he may not have a problem. So you really have to be careful, and maybe you can follow the patient up, but don't alarm the patient. I'll tell him there is one thing normal. We are not sure how good our technique is. It's a new technique, has been evolving for some years, but we are not as comfortable with it as possible. So next time you come in, we'll again check and see how you do. That's what we'll do.
Sir, as Shantanu correctly pointed out,
Yeah.
in this case,
Yeah.
for example, in our case, if the E by E prime ratio is more than 14 or 15, that means he is going for HFF. If the same case, if he does LA strain,
How old is the patient? How old is the patient?
Aroundly 62, sir.
62.
So I
Have you
think
looked at his mitral annular calcification?
No, it is not present in this case, sir. No mitral annular
Because
See,
that is another
problem
important
is the therapeutic
What is,
problem is there, sir. I will put this, if LA strain is around about 18 in this case, I would definitely put direct chlorothalidone
I think
for
he's
this
right.
patient.
In this,
It has got therapeutic implication.
borderline situations where there's a problem, whether to alarm and all, I think the role of LA strain comes. So I think we
Yeah.
can show that if you if
I
time
think
permits.
that's a good point.
Finish
Dr.
the LA
Shantanu
strain
mentioned.
and then we will
But
have this.
E to prime ratio, how good it is? Not really that good. Have you looked at recent data? Recent data, there is it's not,
The only
there's
problem
nothing
is
like 80,
we
90%,
should
not at
not
all.
take one data,
criteria.
one data.
So
for
that's why I'm saying
analysis.
get a pro BNP,
See,
get a stress test, and then try to answer.
there is an LVH. There is a the IAF is normal, reduction in the GLS. The patient has got a diastolic dysfunction, grade 1 or grade 2, going to grade 2. The LA strain is abnormal.
I
Then
think
that
in the
patient
presence of
should
Many
LVH,
things.
definitely
You
it
do
is
the same
abnormal.
thing.
down is
Yeah.
bad.
I think the time is going. It's more than 5 minutes extra.
What is the next? I mean,
Yeah, my next is another.
what is?
No, but
Okay. Do we have anything at 2 o'clock?
yeah, I think there is another session going on. Yeah.
Yeah.
I got another
Do you
session.
want LS strain now or you don't want? Okay. I will quickly show. So, couple of things. Am I audible? Okay. So, whenever you do an LS strain, there are two. Okay, mic is there. There are two schools of thoughts, and now the ESC guidelines have come up how to do it. Well, even for LA volume, don't zoom LA. That has been come up. Don't take LA strain or LA volume by zoom method. Do by LA focused view. So how to do an LA focused view is get an LV view, apical 4-chamber view, and then go one step above. So you are basically foreshortening the LV to bring the LA in prominence. Did you get it? So go to apical 4-chamber view and go one step, one level up. So you foreshorten the LV, so LA becomes prominent. Okay. But unfortunately, this patient doesn't have that kind of view. They have already. So I was just trying to look at this view, and the LA is not that good. Anyway, so he has a where is it? He has a zoomed view. So I will just try to demonstrate. Where is it? It's just okay. For LA strain, you either take 4-chamber view or 2-chamber view. It is not necessary to take both the. If I follow 4-chamber, just do a 4-chamber view. That's one. Second thing, the frame rates should be. See here, the frame rates are going at 133, which is not needed. We need around 50 to 90. So in higher frame rates, the values change. So I'm not going into details, but I'm just trying to tell you, you need 50 to 90. Third thing is there is something called PP gating and RR gating. Means what? So the ECG shows R and R. You can do an RR cycle or you can do a PP cycle. The most preferred is to identify RR cycle. So the machine has set up with RR cycle. Okay, and you identify the structure, go for the LA strain, and it is asking 4-chamber view, and it will ask me the basal septum, the lateral base, and the apex, the LA roof. So remember, LA is a very thin structure. You have to be very careful that you don't go in outside, otherwise the values go haywire, and we process it. I think I had to reduce the region of interest. He's correct, but because of
the minimum.
because it
Millimeters.
yeah, it should be less than 4 to 3 millimeters. It should be around 2 to 5 millimeters. But these are very technical things, and you get beautiful waves. So this is the zero line, okay, and this is one peak, and this is the second peak, right? So this is RR gating. There is an RR gating. Can you change the PP gating? होता है क्या इसमें भी? हाँ? You can also go for a PP gating. So PP gating shows you a negative wave delay, but there is some problem here. So I will go for a RR gating. To simplify, just focus on the RR gating and you get the first positive wave. The positivity is defined by the movement of the AV canal. The AV canals are moving towards the probe. That's why you're getting everything positive. So this is the value. The first value is positive, which is this. It is called PALS. It is peak atrial longitudinal strain, also called the reservoir strain. The normal reservoir strain is around 38%. 38 plus minus 4. So यहाँ पे it is 11%. Anything less than 20% is bad. Okay, 25%, 26%, you have to be very careful. So this patient has 11%, and the second is this PACS. It is around -6. PACS is peak atrial contractile strain. This is also called the booster strain. When the left atrial contracts, roughly it is around 17%. It is here, it is around 6%. And the difference between two, which is called the conduit strain. So for research, for everything purpose, for the patient which we were discussing now, we all need is this PALS from here to here, which is now 11%. So if in our situation, sir, your question, my report will be hypertensive heart disease, LVF of 60%, concentric LVH, GLS of -12.1, PALS or LS strain of 11%. He is in stage B, 100%. So this is HFpEF for sure, and he needs treatment. Whatever, yeah. Any questions? So I will come to Dr. Nanda. What LS strain? LS strain and anti-proBNP level, which one is important? So Dr. Nanda, LS strain, okay. What? I think these two are both independent tools which gives you a lot of information. So if I can tell you, 27% of patients of HFpEF may have normal LVGLS, but may have attenuated LS strain. So there is something called primary atrial cardiomyopathy, where LS strain is only accelerating down. That is the importance. LS strain is helpful in prognosticating a lot of conditions. So the recent, there are a couple of reports where the diastolic dysfunction protocol doesn't fit the borderline situation. So they have suggested, I'm done. This is my last sentence. Anything less than 18% is high filling pressure. That's what they are commenting.
Thank you.
Thank
I think
you.
we have
Right.
to go to the next session.